Today, we're going to tackle something that can feel, well, a little like magic. We're talking about taking a super dense, really complex surgical report from the digestive system and boiling it down into a precise set of CPT codes. You know, it often feels like you're searching for a needle in a haystack, but I'm going to show you a system that changes the entire game. Let's get right into it. So, this is really the central question, isn't it? A surgeon performs this incredibly technical procedure, and our job is to take all that action, all that clinical storytelling, and distill it into one single accurate code. It's a high-stakes puzzle, for sure. Getting it right means everything works. Proper reimbursement, accurate data, but getting it wrong, that can cause some major headaches down the line. And you know what? The solution isn't about trying to memorize thousands and thousands of codes, no way. It's about having a powerful framework, a kind of mental model that brings some serious clarity to all that chaos. We call it the clinical blueprint. And trust me, it's the key to mastering this whole process. Okay, so before we dive into the blueprint itself, we have to lock in the single most important rule that governs this entire code series. It's really the foundation that everything else is built on. Now take a look at this. The way the GI tract is laid out here, from the duodenum all the way down to the rectum, well, the physical path a surgeon or a scope takes directly mirrors the sequence of the CPT codes themselves. The number one driver for your code selection is almost always going to be the physical location of the procedure. So burn this into your brain. In the 40,000 series, anatomy is destiny. If you can just pinpoint where the work was done, you are already halfway to the right code. Think of this idea as your North Star for this entire section. All right, with that foundation solidly in place, let's get to the blueprint itself. This whole framework is built on 5 critical questions. Think of them as master keys that will help you unlock any coding puzzle you find in an operative report. And here it is, the entire system at a glance. These 5 pillars are your checklist every single time. We're looking at the approach, the extent and anatomy, the patient's age, the procedure's intent, and finally, any complications or add-ons. Ask these 5 questions, and the right code, it's just gonna reveal itself. So our first key is approach. This is your starting point. Pretty straightforward. Did the surgeon make a big incision? That's an open procedure. Or did they use tiny little ports and a camera? That's laparoscopic. Or maybe it was through a natural opening, like with an endoscopy. The report will tell you, and making this first decision narrows down your options in a huge way. Second up is extent and anatomy. And you see, this ties right back to our big rule. Anatomy is destiny. For endoscopies, you need to know exactly how far that scope traveled. For a hernia, where exactly is the defect? You're basically creating a little mental map of the procedure right from the words in the report. Okay, the third key is patient age. Now, this one doesn't apply to every single code, but for certain procedures, and I'm thinking about things like tonsillectomies or some hernia repairs, it's absolutely critical. There are often specific CPT codes for patients above or below a certain age, like 12 or 5. It's a variable you just can't afford to miss. Key number 4 is all about intent. What was the goal? Was the surgeon just looking around to figure out what was wrong? That makes it a diagnostic procedure. Or did they actively treat something, remove a polyp, repair a tear? That makes it therapeutic or surgical. This distinction often sends you to completely different sets of codes. And our final key covers all the extra stuff, the complexities. Were there adhesions that had to be cleared out? Was mesh used in a repair? Did the surgeon use a special technique like a snare to get a polyp? These are the details that point you to the right modifiers and add-on codes that really complete the whole picture. All right, theory is great and all, but let's see how this blueprint actually works in the real world. We're going to take our 5 master keys and apply them to a few pretty common case studies. So let's kick things off with a tonsillectomy. Looking at this, we can see those critical variables we talked about. We ask our questions. Was it just the tonsils, just the adenoids, or both? Was this the first time or a secondary procedure? But the most important question here, the one that creates a major fork in the road, is that age threshold. And wow, this table just makes it crystal clear. Check it out. For a combined tonsillectomy and adnectomy, the code is 42820 if the patient is under 12, but it's 42821 for a patient who's 12 or older. Same procedure, different patient age, totally different code. This is the blueprint's age key in perfect action. Okay, on to the next case. Colonoscopy versus sigmoidoscopy. This one is all about our second key, extent and anatomy. The entire difference between these two procedures comes down to one single critical anatomical landmark. I like to call it the splenic flexure tollgate. The rule is just this simple. As you're reading the operative report, you're tracking the scope's journey. The second the report mentions passing the splenic flexure, bam, you've crossed the toll gate and you are officially in colonoscopy territory. Now, if the plan was a full colonoscopy but something stopped the procedure short, well, that's exactly when you'd reach for modifier 53, which basically tells the payer the procedure was discontinued. Let's tackle our final case, hernia repair. Now, this might look complicated, but it's really just our blueprint laid out as a decision tree. You start right at the top with the approach. Was it open or laparoscopic? Then you just follow the path down to the anatomical site. Is it inguinal, ventral, femoral? Then you check for age. And finally, the clinical status. Was it the first time or recurrent, reducible or incarcerated? Each decision just guides you one step closer to the right code family. Now, a super common question with hernias is about the mesh. This slide lays out the rule perfectly. For almost all hernia repairs, using mesh is just considered part of the main procedure. It's baked right into the code. But, and this is a big but, there's one major exception. For an open incisional or ventral hernia repair, you absolutely must use the add-on code plus 49568 to report the mesh. That is a key detail you've got to look for. So, as you can probably see by now, this isn't about guesswork at all. It's about having a systematic process. It's about becoming a decoder, reading the clinical story, and finding the code within it. And here we are, right back to our 5 pillars. This is your mental model, your go-to framework for every single 40,000 series report you open. Approach, extent, age, intent, and complications. This blueprint gives you the structure you need to confidently find the right code every single time. So, what are the big things to take away from all this? First, anatomy is destiny, location is everything. Second, always ask those 5 key questions. Third, be on the lookout for those critical decision points, those toll gates, like the splenic flexure, that completely change the coding path. And finally, just remember that the blueprint is your reliable path through all the complexity. With this blueprint in your toolkit, you're no longer just reading a report, you're interrogating it. You have the tools to see the underlying structure and pull out the correct code with real precision. So I guess the only question left is, what will your next operative report reveal?